Good morning, everyone. I'm Dr. Ulfat Awad, F1 Nephrology, and I'm gonna present a rare case in nephrology and hypertension diagnosed at Zahra Hospital University Medical Center. Case description: 58-year-old female patient known for hypothyroidism on medical treatment, presented to the emergency department with pallor, fatigue, and labs as out, showing an elevated creatinine level. Her history goes back to 1 month prior to presentation, when the patient had flu-like illness. She sought medical advice with a general practitioner who prescribed her a symptomatic treatment including ibuprofen. Labs as out showed a hemoglobin of 7, and since the patient is postmenopausal and she has a hemoglobin of 7 and workup showed iron deficiency anemia, we should rule out malignancy with bleeding, so she was referred to do CT chest abdomen pelvis with IV contrast on out basis from her hemato-oncologist. Creatinine level was checked regularly before contrast administration but found to be very elevated. Review of systems. The patient had dyspnea and chest discomfort for 3 days prior to presentation. At rest, improves by leaning forward. 1 episode of melena without abdominal pain. Anuria since 2 days. Otherwise, the review of systems was negative. Her physical exam was remarkable for tachycardia. The patient was pale, with poorly injected conjunctiva, moist mucous membranes. Lung, cardiac and abdominal exams were normal. Lower limbs edema 2+, without evidence of skin lesions or rash. Her laboratory workup showed hemoglobin of 7.7, normal platelets count, BUN 94, creatinine very elevated at 8.7, ESR markedly elevated at 120 mm per hour. Hepatitis and HIV serology were negative. Urine analysis was not done initially since the patient was anuric. Autoimmune workup was ordered, however, it was still pending at that point. Imaging was done at our hospital, definitely without IV contrast, that showed CT chest, mild pericardial effusion that could be uremic in nature and explains the dyspnea and chest pain that the patient complains of and improves by leaning forward. Bilateral ground glass opacities with multiple infracentimetric nodules. Are these ground glass opacities related to the recent viral illness that the patient had, or it's a part of a more systemic disease that we still doesn't know? Uroscan definitely was done to rule out any post-obstructive uropathy, and it showed no hydronephrosis. So our differential diagnosis, mainly to rule out vasculitis, since the patient has pulmonary, renal involvement, anemia, elevated ESR, rule out interstitial nephritis secondary to NSAIDs intake, rule out glomerulonephritis, rule out hemolytic uremic syndrome, or underlying malignancy with bleeding. The course in the hospital. During the hospital stay, our patient complained of abdominal pain, severe diffuse with soft abdomen, and drop in hemoglobin to 6.5 and platelets count to 125,000. Our first concern was to rule out GI bleeding due to the history of recent NSAIDs intake. Despite that, our patient had no melena, hematemesis, or hematochezia. Gastroscopy was done and showed a clean-based ulcer at the gastroesophageal junction. Colonoscopy was ordered at the same time, however, it was not done due to poor bowel preparation. Still, we have no evidence of GI bleeding, and the patient had a drop in hemoglobin and platelet counts at the same time. In addition, she has renal failure and abdominal pain. So should we rule out hemolytic uremic syndrome? Peripheral smear showed 1 to 3 schistocytes, LDH was elevated, haptoglobin was normal, retic count was elevated but could be related to bleeding rather than hemolysis, Coombs was negative, bilirubin normal, hemolytic uremic syndrome was excluded. Additional laboratory workup, C3, C4 were normal. Normal C3, C4 doesn't mean that they were not low at some point of the patient's illness, so they are not very helpful when they are normal. ANA profile was negative to all, anti-glomerular basement membrane antibodies were negative, C-ANCA antibody was negative, P-ANCA positive. So are we facing a case of ANCA-associated vasculitis? In order to confirm the ANCA-associated vasculitis, we need to do a tissue biopsy. So our patient was scheduled to do kidney biopsy on the next day. However, She continued to have abdominal pain, mainly localizing to the left upper quadrant this time, and a drop in hemoglobin. CT abdomen and pelvis repeated urgently and showed 11 cm splenic subcapsular hematoma with hyperdense fluid around the spleen, liver, and Douglas. So she was referred for urgent splenectomy. Since the patient had a splenectomy, there is no more need to do kidney biopsy. We can do a splenic biopsy. That confirmed a granulomatous vasculitis. And since it is granulomatous, so this is granulomatosis with polyangiitis rather than microscopic polyangiitis. Usually, granulomatosis with polyangiitis are associated in 75% of cases with C-ANCA rather than P-ANCA in only 25% of cases, and the opposite is true for microscopic polyangiitis. This is the granuloma. Treatment. The appropriate treatment for organ-threatening disease is glucocorticoids in high dose in combination with either cyclophosphamide or rituximab. What about our patient? Can we initiate the treatment? After discussion with the pulmonary, their opinion was to rule out superimposed TB infection in a patient with ANCA-associated vasculitis. And after the opinion of ID, they suggested to wait until initiation of vaccination and suggested to prolong the antibiotic duration. And then we can proceed for treatment. So ANCA-associated vasculitis is a group of disorders that include granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. It's a small vessel vasculitis and all have similar features on kidney biopsy, which is the post-immune necrotizing glomerulonephritis. And by post-immune, we mean that there are no immune complexes, no complement deposit, and kidney biopsy. Granulomatosis with polyangiitis and microscopic polyangiitis affect the upper and lower respiratory tracts and the kidneys. It can even present with severe organ-threatening diseases or life-threatening diseases like rapidly progressive glomerulonephritis or lung hemorrhage. It's a rare disease. The prevalence ranges from 2.3 to 146 cases per million persons. The incidence is 0.4 to 11.9 cases per million per year. Most commonly occurring in older adults, both males and females are equally affected. Concerning ANCA antibody, it should be tested in any patient who presents with symptoms suggestive of vasculitis. 90% of patients of granulomatosis with polyangiitis or microscopic polyangiitis are ANCA positive, meaning that a negative P-ANCA or C-ANCA does not exclude the diagnosis of GPA or MPA. Granulomatosis with polyangiitis is associated, as we said before, to C-ANCA in 75% of cases and P-ANCA in only 25% of cases, and the opposite is true for microscopic polyangiitis. The predictive value of ANCA antibody depends heavily on the clinical presentation. For example, if it is tested for a patient presenting with rapidly progressive glomerulonephritis or lung hemorrhage, its positive predictive value is more than 98%. However, its positive predictive value is much less than that in a patient presenting with chronic sinusitis. Negative ANCA definitely does not exclude the diagnosis, as the status of ANCA may change over time. Positive may become negative and vice versa. The clinical features are usually non-specific and most of the time can be misdiagnosed as infection, flu-like illness. These are myalgias, arthralgias, weight loss, misdiagnosed as infection, malignancy, inflammatory joint disease. So when to suspect really granulomatosis with polyangiitis? In the presence of constitutional symptoms with evidence of kidney involvement, upper or lower respiratory tract involvement, or multiple mononeuropathy, laboratory evidence of ANCA antibody, and marked elevation in ESR. The gold standard for diagnosis definitely is a biopsy from an involved organ like the kidney, skin, upper or lower respiratory tract, and lower respiratory tract biopsy is usually thoracoscopic rather than bronchoscopic. It shows granulomatous necrotizing vasculitis versus non-granulomatous in microscopic polyangiitis. So it is the biopsy that differentiates between granulomatosis with polyangiitis and microscopic polyangiitis rather than P-ANCA or C-ANCA. The kidney biopsy shows post-immune necrotizing glomerulonephritis plus crescents if it is rapidly progressive glomerulonephritis. The treatment depends on if it is mild or severe disease. It includes steroids plus cyclophosphamide or rituximab. The role of plasma exchange is mainly discussed with rapidly progressive glomerulonephritis or lung hemorrhage, and it is very controversial. Back to our patient, she had non-traumatic splenic rupture. She doesn't have a history of trauma. What is the cause? It's known as pathological rupture. Upon review of the literature, the identifiable causes were myeloproliferative diseases, vasculitis, hematological malignancies, or infections like EBV or malaria. Only 3 reported cases to be secondary to ANCA-associated vasculitis. So our patient could be the 4th reported case of non-traumatic splenic rupture secondary to granulomatosis with polyangiitis. Thank you.